prosjektleder på Nasjonalt senter for E-Helse-forskning. Jeg er leder i avdeling som heter digitale helsetjenester. Og vi har forsket på innsyn i journal siden 2016. I dette forskningsarbeidet så har vi samarbeid med flere internasjonale aktører. Og en av de er Marie Heggelund, som skal starte med presentasjonen her. Og Marie Heggelund og vi og 2 andre land skrev en forskningssøknad for 1,5 år siden som fikk finansiering. Og Marie er da prosjektleder for et nordisk innsyn i journalprosjekt, hvor det er et samarbeid mellom Sverige, Norge, Finland, Estland, og vi har også samarbeidspartnere i USA. Men de har ikke finansiering, de er bare med i det vitenskapelige arbeidet. Og vi forsker på pasienter og helsepersonell sine erfaring med at pasientene har fått innsyn i sin egen journal. Og vi har et spesielt fokus på psykiatrien og på kreftbehandling. Og det er for at vi har en del funn i Norge innenfor psykiatrien som er spesielt interessant, og i Sverige har de gjort en del funn innenfor kreftbehandlinger som er spesielt interessant. Vi har startet opp med dette prosjektet tidlig i januar i år, og vi har så langt jobbet veldig mye med et spørreskjema. Det spørreskjemaet skal ut i januar 2022. Det er egentlig ferdig, med litt sånne små justeringer etter vi har vært ute og testet det på noen testpasienter. Men det spørreskjemaet skal legges ut samtidig i alle de her 4 landene, altså Norge, Sverige, Finland og Estland. I Norge, for dere, så blir det lagt ut under Helse Norge, så når dere logger dere inn i Helse Norge og går inn i min journal, så vil dere fra ca. 20. januar og 2-3 uker frem i tid få spørsmål om hvilke erfaringer dere har med innsyn i journal. I denne sesjonen så skal vi da få presentasjoner fra Marie Heggelund fra Uppsala universitet. Hun skal si litt om det her nordiske prosjektet som er finansiert av Nordforsk, som heter EHiN, og hun skal si litt om erfaringen fra Sverige med den nasjonale portalen deres. Jeg skal si litt om tidligere studier vi har utført i Norge på de løsningene som vi har her i Norge. Så skal han Vesa fra Finland si litt om erfaringen derifra, og så har vi Peter Ross fra Estland. Han snakker litt mer om de digitale tjenestene generelt i Estland, men også litt om journalløsningen og innsyn i journal. Presentasjonene blir på engelsk, de er tatt opp på forhånd, så de er digitalisert. Men jeg vil være tilgjengelig etterpå for å svare på spørsmål med hensyn til de norske studier. Så vi kan snakkes igjen etterpå. Hei da!
Hi, my name is Maria Heggelund and I'm the project manager for a research project called E-Helse, where we are focusing on evaluating and studying the national patient portals and patients' access to their medical records online in the Nordic countries. And today I would like to share a little bit about the project with you, but I would also like to give you a little bit of insight into how the national patient portal is used in Sweden today. And I am a researcher at Uppsala University, and I've been following the implementation and use of the national patient portal and patients' access to their medical records in Sweden for quite some time. But first, let's talk about the E-Helse project. The project is funded by Nordforsk, and it was one of only 6 projects funded in a call on an innovation program on digitalization of the public sector. And we are actually the only project that had a real focus on e-health in the Nordic context of these 6 projects. And you can read more about the project on our website, where you can also follow the project for updates when we publish new materials, for example, or do presentations somewhere. We have partners from 5 different countries, many partners from Sweden as part of the DOME research consortium that has been studying patients' access to their medical records in Sweden since it began. We also have partners from Estonia, Tallinn University of Technology. We have Aalto University from Finland, and we have the Norwegian Center for E-Health Research from Norway. In addition, we have the Open Notes group from Harvard Medical School in Boston. And the US researchers cannot be funded by the Nordforsk funds, but they find the project interesting enough that they want to join us and help us anyway, which we appreciate very much. The project, as I've already mentioned, we are studying patients' access to their electronic health records online and how that influences opportunities for better self-management and transparency in healthcare. So what we do is that we study the current implementation and adoption in these 4 or 5 countries. We also plan to develop evidence-based evaluation frameworks and guidelines and explore factors around co-design of personal e-health solutions through innovation projects. We have a number of different work packages. We are currently doing a comparison between the socio-technical contexts and policies across these countries. And that comparison is proving to be quite challenging, but also very interesting. And we believe that there are many factors in this socio-technical context that influences both how national patient portals are implemented and how they are adopted in use. We are also focusing on acceptability and usability of these national services. And we have identified a number of areas where we still have some challenges and where it's not really straightforward to implement these types of solutions. One of them is mental health or psychiatry. Another one is oncology and cancer treatments. And a third one is proxy access or children's and adolescents access and parents access to notes. So we have ongoing research projects in all these 3 areas. We're also looking continuously specifically at questions around information security and privacy in these 3 work packages. And finally, we are looking to, and this work is just starting up, looking at co-designing future types of services that could be connected to patients' access to their medical records. For example, looking at patient-generated data, self-tracking data, and co-creation of medical content. So we are very excited about this project, and we hope to be able to come back and share more in future conferences. What we are doing, the data that we are mainly collecting is, we're doing national surveys or questionnaires in all 4 countries, Sweden, Norway, Finland, Estonia, sent out to all of the patients that are logging into the national patient portals. We will also be exploring usage statistics, of course, and we are also looking at gathering qualitative data, so doing interviews and focus groups and co-creation, of course. And we will both analyze these locally in each respective country, but we will also, of course, do cross-country analysis of both the quantitative and the qualitative data, looking for best practices, what can we learn from each other, who's doing interesting things. So we want to do this in very close collaboration with both researchers, practitioners, healthcare professionals, the providers of the national e-health solutions, and of course, the patients and the public. And just to give you a little bit of an overview of what we are doing in Sweden at the moment, or what's happening with the national patient portal. So we've had a national patient portal in Sweden for a very long time, since I think 2013-14. And it's called 1177.se. And 1177 is also the phone number you call if you want advice from a nurse on how to, whether you need to seek healthcare, for example, or if self-care is enough. In February 2021, the site had over 20 million visits, a very steep increase in the past couple of years. In January 2020, we had 13 million visits in 1 month. So it has almost doubled. And of course, it's due to the pandemic. But the website was actually had quite a high traffic already before the pandemic. As you can see, it has been slowly increasing over the years. When it was first launched in 2013, it wasn't a very high demand for the website. And as you can see, we always have this curve where there's a dip during summer and it peaks in January, February every year. But of course, as you can see in the past couple of years, the pandemic has really increased the use of the website. With a personal bank ID or a secure login, you can also log in and use different e-health services on the website. And currently over 9 million people have actually at some point logged into the website and thereby activated sort of their account. This also includes, however, people who might have passed away. So at some point, the number of accounts will be more than the actual inhabitants we have in Sweden. But as you can see, it's quite a high uptake of these e-health services. And it has really, again, skyrocketed during the pandemic. So in January 2020, we had 1.5 million individuals who logged in during January month. And in April 2021, the same figure was 3.4 million, so more than doubled. And there were 18 million logins during that month. And this is, of course, again, related to the pandemic. You log in order to, for example, schedule testing, book appointments for vaccinations, etc. So this has, of course, influenced this a lot. What you can do, which we, of course, in the Nordic Health project find especially interesting, is that you can also access your medical records online. So if you click on journaltjänster, you end up with your medical record, and it looks something like this. So you can access and read your medical records online. And in total, more than 5.6 million individuals have logged in at one point to read their medical records online, which is more than half of the Swedish population. And when you log in, you see all your notes and your lab results and your diagnosis and your more or less everything when you log in. And you can access it like this in a timeline, similar to a Facebook timeline or something like that. And what's interesting is that you also have access to everything, regardless of where in the country you have received healthcare. So the patient portal connects through the national health information exchange infrastructure to all of the different EHR systems or electronic health record systems used throughout the country. And of course, you see the notes as well, in almost exactly the same format as your healthcare providers have written them, with search terms and keywords, etc. And again, the use of this e-service, accessing and reading your own medical records, have also increased rapidly during the last couple of years. As you can see, in the early days, it was quite few users. And this was also part of the reason is that it was only used in certain regions. So it wasn't yet a national service, or not all of the regions had implemented it. It wasn't actually until 2018 that the last of the Swedish regions connected and started giving patients access to their medical records. And as you can see, the uptake has really increased since then, not the least now then during the last years of the pandemic. And part of that reason, of course, is also that this is where you access your test results. So when you've been tested for COVID-19, you log into your medical records to find out the results. We, in the Nordic Health project, we're really looking forward to comparing the experiences between the Nordic countries, and also to see what happens as the pandemic slowly starts to fade away and we start to go back to normal. Will we still see these high numbers of use, or will they start to drop down again, and will we reach more of a plateau of use? And that was all for me today. But please follow our project, the Nordic Health website, and listening to all the other interesting presentations from the other countries participating in our project. Thank you.
Hello, everybody. I am Monica Alice Johansen. I am Director of the Digital Health Service Department at the Norwegian Center for E-Health Research. I also have a small position at the Telemedicine and E-Health Research Group at the Arctic University of Norway. And I have been working about 26 years within telemedicine and e-health, the last years focusing on research. I'm going to talk about health professionals and patients' experience with patients accessing their electronic health records in Norway. I will start this presentation with a few words about the background of this service in Norway. Then I will have a short report on the studies we have conducted and the method in use. The main focus will be on the results, and in the end there will be a short conclusion. Electronic health records is fully established in Norway and have been so for many, many years now. The patient is both the object and also the owner of the health record. In 2001, a law gave patients access to their health records. And in 2011, a national health portal, heldigitaliserte, provided patients with digital services. And in 2013, a white paper stated that digital access to the electronic health record should be one of these services. Patients have access to the electronic health record in 3 of 4 health regions in Norway. In the 4th health region, they are establishing a new electronic health record system, and when this is established, also the patients in this health region will have access to their electronic health records. All documents that are available in digital format are in general available to all the patients. This includes psychiatry reports, but there are some small regional differences. The documents are available as soon as they are signed, and they are available to all patients above 16 and to the parents of children under 12. The patients also have an access log as part of this service, where they can see who has accessed their health information, including who has read their health information. We conducted 2 studies in 2016, one collecting patients' experience and one collecting health professionals' experience, and both conducted through use of service. The patient service was published on the national health portal heldigitaliserte and was available after secure login. This study included citizens from 2 health regions. The survey collecting the health professionals' experience was sent to the health professionals in Northern Norway. This was the first health region that offered the patients digital access to their own electronic health records. This study was conducted after 1 year's experience with the service. In 2018, the survey to health professionals was sent to all 3 health regions, but the results I will present here will mainly be from 2 of the health regions. This is because of some minor changes that was made in the survey that was sent out in one of the health regions, making it difficult to compare all the answers. Now we are going to look into some of the main findings. You will find the references to the publications, including all the authors, below the presented results. We asked patients why they as a patient used the service. Nearly 25% said that they used the service to share journal documents with family or friends. 37.5% said they shared journal documents with their GP or other health professionals. 64% said that they used the electronic journal to be more prepared to an outpatient visit or an hospital admission. Nearly 88% said that they used the service to better follow up on their treatment, and 88% said that they used the service to look up information they received from their health providers. We asked patients more questions about their experience, why they used the service, and how satisfied they were with using the service. More than 73% said that they felt they could better influence their treatment after using the service. More than 79% said that it was easier to communicate with health personnel. More than 81% said they had a better understanding of their own health. And more than 85% said they understood most of what they read. More than 87% said they was better prepared to a hospital visit or admission. More than 89% said they experienced increased safety when using the service. More than 92% said it was easier to keep an overview of their own health. And more than 92% said they in general was satisfied on how the service worked. When it comes to the health professionals' experience, I'm only going to present the main findings. One of the main findings was that 21.4% found that patients was better informed about diagnosis, treatment, or follow-up after the service was introduced. 67.5% expected more patients to have basic knowledge of health status in the future. Another finding was that 28.3% of the health professionals experienced patients or relatives referring to information they had found in the electronic health record. 19.6% of the health professionals plan to use this service in future follow-up, for example, by adding more information to the patient in the record. Some of the questions was also answered by administrative staff. And here we saw that more than 25% of the administrative staff and more than 50% of the health professional received feedback from patients regarding mistakes or missing information in the electronic health record. We also found some differences between psychiatry and somatic care. 43.9% in psychiatry care versus 23.6% in somatic care changed the way they wrote in the electronic health record. And as many as 60% in psychiatry care versus only 15.2% in somatic care discussed with colleagues whether to deny a patient access to information in their electronic health record. Some respondents provided additional comments in an open text field. Most comments came from the psychiatry field, and nearly 80% of the comments from the psychiatry field were critical, compared to only 43% from the somatic field. The main concern was that this service was not considered suitable for all mentally ill patients. Example on unsuitable patients groups were patients with severe mental disorder, for example psychosis, paranoia, where reading the electronic health record could worsen the situation. Another example was children with parents accessing the electronic health record on their behalf, if the parents were in a conflict situation, or if the child was at risk of abuse. Another example was adult patients that could be threatened to show their electronic health records to others. Some of the health professionals denied access to information they worried could harm the patient or their relationship with the patient. Some had started to omit information from the electronic health record. And a few also reported writing a hidden or shadow record on their computer or on paper containing information they didn't want the patient to read. Others suggested to delay displaying the electronic health record documents, for example, until after completing of a therapy period in psychiatry. A number of respondents from both fields commented on that this service could complicate their work, could cause more work, and it could even worsen the treatment. They had to spend more time to evaluate what to write or not. They had to write in a manner that patient would not find offensive, and they had to consider who they wrote to, young, old, or very sick. They also comment on that the decision to deny access to information could harm their relationship with the patient, when patient could become suspicious and mistrusting. They also comment that patients' access to electronic health record could make it complicated to reflect on patients' symptoms through documenting suspected illness. A health professional working in psychiatry stated that, "I think it's not right that patients in psychiatry should have access to their journal. A fear of writing something offensive. I think many therapists unfortunately have to do double journal entries, which again is vulnerable to getting lost. I denied access when I know it's information that can be a trigger for the patient, but frankly, within psychiatry, there's a lot to be offended by, especially if you're mentally ill, and it could be impossible to predict what someone sometimes can take offense at." In 2018, we conducted a new study on health professionals' experience with service. We based this survey on the questions from 2016, and we added some new questions to dig into the findings from 2016. In this study, we found that 24.7% of the health professionals found patients better informed about diagnosis, treatment, or follow-up than before the patient got online access to their health records. We found that around 20% wanted to use the journal more actively in following up on patients. We found that almost 1/3 spent more time on writing. In psychiatry care, this was 38.6%, and in somatic care, 26.1%. We also found that almost 1/3 changed the way they wrote. In psychiatry care, this was 39.1%, and in somatic care, 27.2%. In the Northern Norway health region, we included some questions about writing a hidden journal or other informal ways of making information inaccessible for the patients. We found that 29% of the health professionals in psychiatry had not reported all relevant information in the electronic health record last year. For somatic care, this number was 18%. In addition, we found that over 8% of the respondents in psychiatry care had reported that they had written off the record, or called hidden or shadow records, during the last year. This means that they had reported patient information outside the official electronic health record system. A study based on survey data from all the 3 health regions using this service in 2018 looked into how and why health professionals in mental health care have changed the way they write. We find that some health professionals modified their journal input, often so that it was comprehensible to patients or did not offend them. The results may point to a dilemma for health professionals in balancing the needs and obligation to record relevant observations with consideration of how patients may comprehend and react to the notes when accessing their medical records. So to the conclusion. I have reported from 4 studies, and I reported several important positive findings. Patients find this service very useful. Patients identify mistakes in the electronic health record. And patients are better informed about diagnosis, treatment, and follow-up than before. But the service might have put an additional burden on some health professionals, especially those dealing with mental health patients. Health professionals working in mental health questions if this service is suitable for the sickest and most vulnerable patients. Some adaptations, instructions, or training might be necessary to make the service more suitable for the mental health field.
Dear audience, my name is Vesa Jormanainen and I work as a chief specialist at the Finnish Institute for Health and Welfare. This is a presentation on use of the National Patient Accessible Electronic Health Record in Finland. The Finnish Patient Accessible Electronic Health Record, My Kanta, is part of the Kanta services, which is the name of the comprehensive Finnish national, centralized, integrated and shared data system services for healthcare and social welfare services, community pharmacies and citizens as well. These services form a unique statutory nationwide service concept, and they have been introduced in phases in a step-by-step manner since May 2010. The national Kanta services form a bunch of centrally maintained and developed IT services for user groups shown on the upper left-hand side. We also show in the lower left-hand side the main standards that are used within the national Kanta services. My presentation will focus to my Kanta or my Kanta pages, and as part of the repositories that show data from persons, the prescription center. So first, a couple of charts regarding my Kanta. That service was launched May 20th, 2010. The features of my Kanta include viewing e-prescriptions, requesting a prescription renewal, printing out a summary of e-prescriptions, and viewing health data. The third category includes viewing and removing personal well-being data recorded via well-being applications. In addition, one can give his or her consent to or limit disclosure of personal data. One can also save a living will and organ donation testament via my Kanta, or one can act on behalf of dependents under 10 years of age, nowadays also including older age groups. In addition, one can manage consent for electronic prescriptions in Europe and can access and print out or copy in PDF format the COVID-19 certificate. On this slide are presented two time series, the data of which is monthly based. The first one is the number of visiting persons per a month, and the other one is sign-ins to my Kanta per month. I have described also vertical lines at the beginning of the year 2020 and the beginning of the year 2021 because of happenings when it comes to COVID-19 activities in Finland. On this slide you have two maps that provide data on the municipality level, and the data is on the proportion of adults who are at least 18 years old, who have at least once signed in to my Kanta services in 2017 on the left-hand side and 2020 on the right-hand side. And as you see, overall 42% of the adults in 2017 did so, whereas a huge increase up to 63% in 2020. The more red, the less is the proportion. The greener the color, the more is the percentage of proportion. When it comes to the use and users of the my Kanta pages by age group, we observed that less than 5% in 2020 had used or signed in to the service, whereas 2 out of 3 in the working age group and half of those aged at least 65 years. I'm very proud to show you that 1/3 of those who are 75 years or older did also sign in to the my Kanta pages. Possibility to request a renewal of electronic prescription became effective in November 2015. Here you have a time series based on a monthly number of repeat renewal requests sent to healthcare via MyKanta pages. And as I have highlighted, there's a spike of requests in March 2020 due to COVID-19 activities in the country. Caregivers acting on behalf of their dependents or their children less than 10 years became effective in October 2016. Here you have monthly time series of these acting events, and as highlighted, there's a huge spike and increased level of this service utilization since August 2020 due to the activity of COVID-19 in the country. The Finnish National Prescription Centre was launched in May 2010 and has ever since recorded all the electronic prescriptions and dispensing events. The first Finnish electronic prescription was issued and dispensed in Turku, Åbo in late May 2010. And after that, the implementation of the services of the prescription center were step by step taken into use by pharmacies, meaning community pharmacies, public healthcare service providers, and private healthcare service providers. The electronic prescribing became mandatory the 1st of January 2017. Here you have a time series of two different curves. The upper one being dispensing events and the lower one being number of electronic prescriptions recorded to the service. And as we see, the number of recorded electronic prescriptions has been on a decreasing trend since the 1st of January 2017, whereas the dispensing events are still increasing, but showing a kind of saturated model. So that was briefly a kind of view what we have when we talk about use of the national patient accessible electronic health record in Finland, being known better as My Health. After this closing slide, there are a couple of additional ones pointing to reference articles. Thank you very much that you chose this channel.
Dear colleagues, this talk is about digital health in Estonia. My name is Peeter Ross. I'm E-Health professor in Tallinn University of Technology, and I'm also a radiologist in East Tallinn Central Hospital, Tallinn, Estonia. This is the agenda of today's talk. I will start with about some facts from Estonia. Estonian population is 1.3 million inhabitants. We have, similarly to Nordic countries, ID code, unique ID code of every citizen. And this is a basis of any e-service. So this is both the physical and also digital entity of the person. Talking about e-health, we have to talk also about other e-services in Estonia. We have vast majority of services, public services in both modes, either in conventional, paper-based or electronic. So basically all public services are online. Estonia has several advanced technology companies, just to name Wise, Bolt, Skype, some of them. We also have highest number of unicorn companies per capita in the world. And there are several e-services, as I mentioned. Among of them is e-residency. So every person in the world could also apply for e-residency of Estonia and use these services worldwide. Estonian students also rank high in PISA results. Healthcare system is similar to Nordic countries, so we have universal health coverage. The insurance is paid by the employers. It's 13% of payroll tax. And as you see, our healthcare costs make up only 6% of GDP. Healthcare providers are either private, municipal, or governmental. And then hospital system is mostly publicly owned private hospitals, while GPs are private entrepreneurs. Estonian health information system is quite unique because it covers all the country, encompasses the whole country, registers virtually all citizens, not only citizens but also residents from the birth to death. And it's based on the same comprehensive standard-based IT infrastructure as other e-services in public sector. This is the architecture. This is a pretty busy slide, but this is important to understand how Estonian E-Health system works. So on the right upper corner, there are data providers, healthcare institutions which are generating health data. Hospitals, pharmacies, GPs, school nurses, emergency, they all have their own electronic medical records, so there is no universal electronic medical record for the whole country, but healthcare providers are free to choose their EMRs. Then on the left upper side there are state-owned registers. In Estonia, the concept of e-services is that the data should stay where it is generated. So if, for instance, we need to know about the person, then there goes a query to the population registry, not that the population registry is duplicated in any other database. And these registries and healthcare providers are connected with each other through a secure data exchange layer, which is provided by the state. It's called X-Road. And this enables secure internet-based data exchange and reliable, very secure identification of users and also service providers. On the right lower side, there are central e-health services. They are cloud services where either electronic medical records, prescriptions, claim management documents, and also images are shared. And this kind of architecture enables to apply different e-services for the whole country, not just for the institutions. Here are some nice examples that, for instance, drug-drug interaction database is applied to all prescriptions in Estonia, which means that it doesn't matter where the new prescription is issued. If there is a drug what is already prescribed and contraindicated, there will be an alert on the desktop of the physician. On the left lower side, there is access for a citizen and for also smaller healthcare providers who don't have their own EMRs. So all these services what are available for healthcare professionals are also available for the citizen. Here is a list of the available documents and services what we provide through the health information system. There are agreed documents, data like time-critical data, GP and hospital summaries and so on. Then nationwide electronic health record system services like e-prescription, e-referral, e-ambulance, drug-drug interaction service, what we discussed already, or then cross-sectoral services, which means that you can apply for the driver license health certificate through the web portal of the road office, and then get also online access to the data what will prove your ability to drive from the perspective of your health. And what is the most exciting and newest service is cross-border service. We today have already up and running mutual acceptance of e-prescriptions between Finland and Estonia. So it means that when you are in Finland and you would like to buy your drugs, and if you're from Estonia, this is possible. How Estonia stands in Europe with its E-Health system, as you see, in 2018 there was benchmarking about the deployment of E-Health among GPs, and in both electronic health record adoption and health information exchange adoption, Estonia, like other Nordic countries, stand in the very first places. Even though our system is pretty advanced, we have clear shortcomings today. And this table is to illustrate the situation depending on the data user perspective. And as you see that even though for the healthcare professionals and patients, the access to the electronic data is very well arranged, then hospital management, also research data are still is not so well connected, not talking about the policy making. So indicators and other reports what are needed for policy making are compiled quite often either in separate information systems or even manually. Health insurance exchange is exchanging also electronic documents and electronic data, and is pretty well advanced. So as you see, the secondary use of data in Estonia is not as well digitalized and covered with e-services as operational primary data use. So based on this, what are now our next steps? How comes the motivation to create new services? Obviously, electronic health information system is run and provided by the state, which means that it lags a bit behind of private initiatives, so integration of new applications from third parties is cumbersome. Development of new services is slow. And as we discussed, also analytical services are hard to implement because of poor quality of data. And we know that people, ordinary people, look on the services rather than on data, so there is a lot of room to improve third-party services. What are the next developments if we look from the E-Health strategy perspective and based on the current, based on the analysis of current situation? So we still have a lot of free text in the electronic medical records, which means that we need improve data quality and we have to structure more the data. This allows us more automatic secondary use of data. We need to provide patients and citizens with more e-services. Also address systemic weaknesses in cross-sectoral information exchange, so that secondary use of health data would be more automatized. We need to improve the exchange of information between hospitals, primary health care, and also between those healthcare providers and social welfare institutions. And finally, this is, I think, applies to any public e-service. The user friendliness is important, and we need to use more and more electronic medical records, digital data to improve our care quality, both from the medical and social care perspective. Thank you very much.
Tusen takk for alle dere som har hørt på. Som dere observerte, så var det ikke helt topp lyd på min presentasjon og på VESA sin presentasjon. Det var litt forstyrrelser, så jeg beklager det. Dere har også sikkert observert at det en del ting som likt i de her landene, men det også en del ting som ikke helt likt. For eksempel så i Sverige så har de innsyn også i primærlegene sine journaler. Det har ikke vi i Norge, noen ting vi håper at vi skal få om ikke så alt for mange år da. Kan vi også nevne Helse Midt, som ble nevnt her, som ikke har fått innsyn i journal lenger. De får jo nå snart Helseplattformen, og da får de en tjeneste for innsyn i journal som veldig spennende. De kan få innsyn i sann tid, og de kan også få til løsninger som gjør det mulig for pasientene å kommunisere med helsepersonell. Så vi veldig, veldig spent på det som skjer i Helse Midt. Som dere også observerte, så det en del utfordringer i psykiatrien i Norge. Det kanskje ikke så store utfordringer, men det en del utfordringer som vi ønsker å se på videre i dette EHiN-prosjektet. Så nå lurer jeg på om dere har noen spørsmål eller noen kommentarer. Alt tillatt. Alt var klinkende klart. Du kan få låne mikrofon.
Okay. Nå skal man jo begynne å dele journaldokumenter via kjernejournal. Og det jo også et sånt aspekt rundt dette med deling mellom helsepersonell. Kommer dere til å se noe på det? Liksom, hva gjør det med hvordan man skriver journaler når man må dele med helsepersonell? Det har jo vært blant annet Helseplattformen, så har jo vært veldig mye fokus på hva fastleger skal dele med andre, hvor det snakk om at fastleger ofte har litt sånn fortrolig samtale med helsepersonell, med pasienten, og på en måte ikke ønsker å dele det med andre helsepersonell. Det noen områder dere ser på?
Det har ikke vært det ikke noen planer per nå om å se på det her med deling som skjer i kjernejournal. Men vi har jo gjort studier i kjernejournal før. Og vi har en del ting som inngår, altså studier i kjernejournal i forbindelse med at hjemmesykepleiere nå har fått tilgang til medisinsk informasjon gjennom kjernejournal. Så det forsker vi videre på. Men de tingene du tar opp absolutt veldig interessant og veldig relevant å se på i fremtiden. Det her med deling av informasjon, sånn som jeg har forstått det, så det i første omgang primærlegene som får tilgang til henvisninger på krise og en del informasjon fra spesialisthelsetjenesten. Stemmer ikke det? For det jo et forsøk nå i Helse Sør-Øst, og så det lett i Bodø kommune, hvis ikke jeg husker helt feil. Og det jo veldig spennende, for at kanskje kan veldig mye av det som skulle bli en innbygger i en journal, faktisk realiseres gjennom kjernejournal via deling av informasjon. Så det en kjempespennende tematikk som vi absolutt burde se videre på. Skal vi se, det var det ene tingen du kommenterte på. Var ikke det en ting til du kommenterte på?
Det med fastleger og dette med forskjellen på notater som skal deles viktig.
Ja, den på en måte bekymringen rundt det å dele, og hva du deler for noen ting. Altså, i Sverige, i Norge også har det vært bekymring når vi nå fikk innsyn i journal i spesialisthelsetjenesten. Og i Sverige så åpnet de jo fordeling i primærhelsetjenesten og spesialisthelsetjenesten samtidig i noen regioner. Og den bekymringen var da selvfølgelig hos helsepersonell, både i spesialist- og primærhelsetjenesten. Men den har gått over den bekymringen. Altså det har vist seg å fungere veldig bra. Men jeg gjorde selv studie i primærhelsetjenesten i 2008, hvis jeg husker rett, hvor jeg intervjuet 19 primærleger i forhold til hvordan de skrev i journalen. Og det var veldig interessant, for at noen sa at de skriver ingenting i fritekstfeltet, det trenger de ikke. Noen skrev langt og veldig utfyllende, noen skrev på norsk, noen skrev på engelsk, noen skrev på sitt morsmål. De brukte ulike forkortelser, og noen sa at de skrev det sånn at de skulle skjønne det, men ingen andre. Og det er klart at det vil jo ikke fungere. Men vi ser jo her, fra både psykiatrien og somatikken, og spesielt i psykiatrien, folk endrer måten de skriver journal på. Det er veldig mange, 1/3 har endret måten de skriver på i journalen. Og sikkert mange som også endrer det uten at de er bevisst at de har endret det. Så i deling av journal i primærhelsetjenesten vil nok medføre at også primærlegene vil endre måten de skriver på i stor grad. Men det er ikke sikkert at det er så negativt. Det kan hende at det er veldig bra for kvaliteten. Så vi får se.
Bare litt spørsmål rundt dette som ble sagt her, da, at journalen og innholdet er jo pasientens, eller opplysningene er pasientens eiendom, og det er for så vidt greit når det gjelder fakta og diagnoser og konklusjoner og sånn. Men i psykiatri spesielt da, så tenker jeg på hypoteser, arbeidshypoteser, alt som ikke blir sagt, men som man kanskje lager noen hypoteser rundt, er jo da et faglig arbeidsverktøy. Grenseoppgangen med hva som er pasientens opplysninger, og hva som er en fagpersons hypoteser og arbeidsverktøy. Kan du si noe om det?
Det er det som er det vanskelige dilemmaet. Og det er det vi ser i de siste undersøkelsene vi har gjort, at det her er blitt en utfordring for helsepersonell i psykiatrien. De føler at det er ikke alt de kan skrive i journalen lenger, så de har begynt å skrive, de brukte utelate informasjon. Det var vel så mye som 29% innenfor psykiatrien som utelot informasjon innimellom. Og det er ganske mye. Og hvis jeg husker rett, så var det 8 eller 9% som noen ganger skrev skyggejournal. Det vil si at de skriver en journal enten på papir eller på sin egen PC om den pasienten, fordi at de tør ikke ta risikoen på å skrive alt det inn i journalen. For de mener at det kanskje ikke er bra for deres relasjon til den pasienten, eller for behandling av den pasienten, hvis de leser alt det her. Og da får du et problem i forhold til den loven om hva som skal dokumenteres i journalen, og i forhold til at det her skal være også et arbeidsverktøy for andre behandlere. Så det er et stort dilemma, og det ønsker vi å se videre på. Vi skal gå inn nå, og så skal vi blant annet gjøre intervju i psykiatrien av de som har de tunge psykiatriske pasientene, og høre med deres erfaring. For vi har tidligere gjort intervju på dagpasienter, og der har vi ikke funnet så mange erfaringer, men vi samlet jo opp, eller fant de her erfaringene når vi gjorde en spørreundersøkelsen, så vi vet jo at det problemet er et problem. Men vi har ikke funnet noen når vi har vært ute og intervjuet som kan utdype problemet, men nå går vi inn altså på de tyngre pasientene, de som er inneliggende, og ser om vi finner noen erfaringer der. Så vi forfølger den saken videre. Det er helt klart en utfordring. Flere kommentarer, spørsmål? Hvis ikke så sier jeg tusen takk for at dere kom. Og så snakkes vi gjerne igjen senere.